So today we will be continuing our discussion on the pituitary and hypothalamus ng mga hormones. So I think the last time that we ended our discussion on the growth hormone. So just a little recap lang. Um, so let's see. Growth hormone, also known as your somatotropin, and then inhibitor niya would be our somatostatin. Okay, so your somatostatin inhibits growth hormone, TSH secretion, insulin, and several gut hormones such as motilin, secretin, and also gastrin. Okay, we also have under your somatotropin, you have IGF 1, or also known as our somatomidin C. This negatively feeds back on the pituitary gland to inhibit growth hormone secretion produced from the liver and is a biological amplifier of the growth hormone levels. It's a major growth factor induced by growth hormone. Okay, ghrelin, also known as their hunger hormone, is produced by the gastric neuroendocrine cells by the hypothalamus and binds to growth hormone secretagogue receptors and stimulates the secretion of our growth hormone releasing hormone in the hypothalamus and subsequently our growth hormone. So our ghrelin increases appetite and regulates glucose metabolism. So in children, the growth hormone target tissue would be the long bone, and it secretes in a pulsatile fashion, and 70% of it um, is being secreted during stage 4 sleep, or the part where it's called slow wave. Okay. Other stimuli of our growth hormone would be major stress, fasting, steroids, chronic malnutrition, uncontrolled diabetes mellitus, and high protein meals. For the measurement of our growth hormone, the method is chemiluminescent immunoassay, but the gold standard measurement for growth hormone deficiency would be our insulin tolerance test. However, our insulin tolerance test is considered as unpleasant for patients, requires attendance of physical during tests, and contraindicated for cardiac, cerebrovascular disease, and seizures. Okay, pag-decrease ang insulin tolerance test, we can do growth hormone measurements following pharmacologic stimulation. And if increased siya, it can be confirmed by growth hormone suppression following an oral glucose load. Okay. And then another secondary or confirmatory method, if you are unable to do the insulin tolerance test, would be the arginine stimulation or in combination with our GHRH. And then another alternative would be the glucagon stimulation test. Okay. Screening for the growth hormone deficiency in children would be through the exercise test. If it's normal, then no further testing is needed, and if there's no increase in growth hormone, then pharmacologic testing is warranted. Reference value for our growth hormone in normal na levels would be less than 1 nanogram per ml or less than 1 microgram per liter. For this would be 70 to 80% of our growth hormone, and it peaks at 20 to 40 microgram per liter. If the glucose drops, if our glucose or our blood sugar drops to less than 400 nanogram per ml, this could be considered abnormal if in adults it does not stimulate a rise of 2 to 5 nanogram per ml, or if in children it does not stimulate a rise of 10 nanogram per ml. So, bale, the drop in our glucose levels, the blood, should be able to stimulate an increase of growth hormones para sa both adults and children. At least 2 nanogram per ml for adults and at least 10 nanogram per ml for children. Okay. So, clinical significance niya when it comes to decrease. So we have disease or disorder involving deficiency. We have the idiopathic growth hormone deficiency, which is the most common cause of growth hormone deficiency in children. And then we have pituitary adenoma na siya. This is the most common etiology in adult onset growth hormone deficiency. And then we also have your growth hormone in childhood, which is defined by the failure of serum growth hormone to reach defined levels when at least two different pharmacologic stimuli are used. Okay? Kung increase na po siya, we have organomegaly, okay, growth in some of our organs such as um, thyroid, thyromegaly, but rarely hyperthyroidism. So we also have your acromegaly. This is a condition that results in overproduction of growth hormone, most as a result of pituitary tumor, and that develops before closure of the epiphysis and may result in gigantism and presents in adulthood, causing diffused enlargement of soft tissues and organs throughout the body. So, ang characteristics niya, as you can see, we have prognathism, or the protrusion of the upper or lower jaw, or both. So, you can see here, okay, nagka-protrude siya. We have frontal bossing, which is the protrusion of the frontal bones of the forehead. Okay, so nag-protrude both ang jaw and ang frontal or ang forehead. And then we have spade-like hands, excessive sweating, and also heat intolerance. Okay, for the screening of our acromegaly or increase in growth hormone, we could do a random collection of our IGF-1. If increased ang IGF-1 na to, or borderline siya, we would need to do confirmatory test, which would be the OGTT 75 gram or 100 gram glucose load. Okay, so first we have to obtain blood glucose every 30 minutes for 2 hours and observe non-suppressibility of growth hormone or to glucose loading, or if it fails to drop to -1 ngml, which is the normal or reference value for adults. Okay, the normal result should be masuppress ang growth hormone level to um, less than 1 ng per ml at any time during the test. If it fails to do that, then we can confirm diagnosis of acromegaly or an increase in our abnormal increase in our growth hormone. Okay. So other causes of failed growth hormone suppression would be puberty, which usually causes an abnormality in IGF-1. Um, then we have uncontrolled DM, malnutrition, hepatic disease, and renal disease. And then the treatment, we have transphenyidal adenomectomy, which ang goal niya would be tumor ablation or the removal or destruction of the tumor. It can consider na cured na ang patient if nag-go back to normal levels na to ang growth hormone or there's a normal suppressibility of glucose. Okay. In terms of clinical significance, so it is decreased hypopituitarism. So this is P supposedly. Hypopituitarism, failure of the pituitary gland or hypothalamus. And this usually leads to loss of the pituitary gland or loss of anterior pituitary function. If it's complete loss, it's called panhypopituitarism. If it's only one loss, it is monotropic hormone deficiency, or there is a loss of the tropic hormones. So, if ang tropic hormone ang lost, then there is a function or functional cessation of the endocrine gland. But if there is a loss in the direct effectors, it's usually not readily apparent. Okay, so that would be it for our anterior pituitary hormones. Next, we have our posterior pituitary. Okay, under sa posterior pituitary, first we have our oxytocin. Okay, so functions of our oxytocin, we have uterine contraction late in labor. Okay, we have hemostasis at a placental site following delivery. It stimulates myoepithelial cells surrounding the mammary glands and is responsible for sexual arousal and orgasm. Okay, ang stimuli for our oxytocin would be the stretching of the cervix and vagina during parturition, also known as our Ferguson reflex, and psychological, such as the anticipation of nursing or hearing a baby cry, can also cause or stimulate our oxytocin release. An inhibitor of our oxytocin would be stressful situations, which is usually results in decreased milk ejection. And then pitocin or pitocin is a synthetic oxytocin used to induce labor. So usually, if a mother is having trouble or having a longer than normal time para mababa ang baby or dugay kaayahan labor, then it can be induced using oxytocin or synthetic oxytocin, in this case, pitocin or pitocin. This is usually introduced to the mother via intravenous na line. Okay. The measurement of our oxytocin is rarely demanded due to its half-life of 2 to 3 minutes, which means it is rarely degraded by oxytocinase. Okay, that's why medyo rarely demanded jud siya. Next, we have your arginine vasopressin or your antidiuretic hormone or your AVP or ADH. The function of this is to maintain osmotic homeostasis by regulating water balance. So it stimulates the V2 receptors on principal epithelial cells that line the cortical ducts of the kidney, and it maintains blood pressure, volume, and also tonicity. Okay. So it induces an increase in the production of your cystic adenosine monophosphate, which increases water permeability and reabsorption. Ang stimuli niya would be serum osmolality of more than 295 milliosmol per kilogram, and it is suppressed pag mubaba ang serum osmolality. Okay. The fail-safe mechanism for fluid and osmotic homeostasis would be thirst, as it is initiated at a greater plasma osmolality than is needed to initiate ADH secretion, and the receptors are located in the hypothalamus. So what our ADH usually does would be the reabsorption of the water. So it keeps us from getting dehydrated. Okay. So usually pag naga ano ta, if there is something that causes us to possibly be dehydrated, naga-cause po siya og an increase in our vasopressin. Okay? But aside from our vasopressin, we also have our fail-safe mechanism that the body also induces, which is it gives us a feeling of being thirsty. Okay, so that dehydrate as well. Okay, it doesn't just cause a surge of vasopressin, but also induces the feeling of thirst. So other factors that can cause an increase in our ADH would be nausea, cytokines, interleukin 6, hypoglycemia, hypercarbia, and nicotine. Okay. The reference value para sa atong AVP would be plasma osmolality of 280 to 295 or a plasma sodium level of 135 to 145 millimole per liter. Measurement of this, if direct, would be plasma freezing point depression, and if indirect, we have your plasma. You can use plasma sodium, BUN, or through glucose. And just if we want to calculate the plasma osmolality, it would be 2 multiplied to the value of sodium plus glucose divided by 18 plus the BUN divided by 2.8 will give us the plasma osmolality. So sodium is considered as the major plasma solute. Okay, if baba ang ato ang sodium sa blood, it could also be equivalent to hypoosmolality. And there are two situations where directly measured and calculated osmolality does not agree. We have first the pseudo-hyponatremia, also known as your factitious hyponatremia, and then we have presence of high concentration of other effective solutes. So sa pseudo-hyponatremia, The plasma volume is displaced by high concentration of lipids. So there is usually decreased plasma sodium. Okay, and but however, the sodium activity in water is normal, and the sodium can be directly measured through uh, ISE. Okay, ISE is usually the method na ginagamit for our electrolytes. Next, we have the presence of high concentration of other effective solutes such as glucose, contrast agents, mannitol, or ethylene glycol. Okay, it causes a shift of water from the intracellular to the extracellular compartment. So the most common situation causing a large osmolar gap would be our ethanol intoxication. Okay. Next, we also have your diabetes insipidus. It causes a large passage of dilute urine in the face of inappropriately elevated plasma osmolality. We have two classifications of diabetes insipidus. We have the central and we have the nephrogenic. If it's central, there is an absence or decreased ADH secretion from the hypothalamus to the neurohypophysis. If it's nephrogenic, there is a certain renal resistance to the actions of ADH. Okay? So, pag central, ADH ang problema. Pag nephrogenic, ang kidneys ang problema. Okay? We could do water deprivation test, which is a preferred diagnostic test for the identifying the presence of um, diabetes insipidus. Okay? So here, we can see under the water deprivation test, if it is neurogenic DI or neurogenic um, diabetes insipidus, there's a decrease in ADH and the kidney rapidly acts to conserve water in response to exogenous ADH administration. So, walay problema sa ato ang kidney. However, the hypothalamus or the posterior pituitary gland could be the problem because of the decreased ADH. If it's nephrogenic, there's nothing wrong with the gland that secretes the ADH, so it could cause a normal or increased ADH under if you're deprived of water. And the administration of additional ADH has little or no effect on renal water absorption because if nephrogenic ang ato ang DI, na ay problem ang reabsorption sa kidney. Ang function ana sa kidney ang problema. Next condition is we have your primary nocturnal enuresis. So it is a common condition where there is decreased ADH levels that have been found in children, and the levels are slightly lower than the control. The symptoms are reliably ameliorated by vasopressin therapy. So in order to check, we could do a first morning urine specific gravity. It is reliable in identifying children who may benefit from ADH supplementation. Okay? So usually, ang ginapangita nato is a urine specific gravity of less than 1.015. This is for children. And if ingan ani ang specific gravity nila, then they may be able to benefit from the ADH supplementation. Okay, so that is it for our uh, hormones from the pituitary gland. Next, we'll go to thyroid function. Okay, so ang thyroid ni mo makita siya somewhere sa imong neck. So normal thyroid gland is usually 12 to 25 grams. It is a two-lobe gland connected by isthmus. Okay, the lobules have 20 to 40 follicles, and the site of the thyroid hormone synthesis and storage. It is a ring-shaped. Makita ninyo? It is like a ring-shaped structure formed by a single cell band of follicular cells. We also have what we call our parafollicular cells or our C cells, which is responsible for the synthesis and secretion of our calcitonin. It's a calcitonin is the hormone necessary in calcium metabolism. So how do we explain ang katong secretion of our T4 or T3, which is our thyroid hormones? So from the hypothalamus, usually, di ba, hypothalamus, nagasecrete siya og uh, TRH, okay, which stimulates the thyrotrophs of the anterior pituitary gland. Okay, and then eventually mag-secrete of TSH, and the secrete in our TSH stimulates the thyroid hormone synthesis, which eventually secretes T4 and T3. So our T4, also called our thyroxine, is 100% of thyroidal origin. Okay, and there is about 85 micrograms of T4 produced daily. 70% of the T4 is bound to our um, TBG, and then 20% is to transthyretin albumin. So both of these are proteins. Ang isa is a globulin, ang isa is albumin. Okay. So 70% is dito sa globulin and 20% sa albumin. Only 0.03 is unbound and are metabolically active. Okay. That's what we call our free T4 or FT4. Okay. Next we have our T3 or 353 triiodothyronine. 20% is of thyroidal origin and 80% is produced enzymatically. So our T4 is 100% from the thyroid. However, T3, 80% or majority of it is produced enzymatically. About 8.5 microgram is produced daily and most is bound to our globulin with 10 times decreased affinity. And only 0.3% is unbound and is metabolically active. Now, sa ato ang iodine, this is the major component of our thyroid hormone, and a major source niya is the dietary intake. Okay? An increase in TSH augments uptake of iodide into the follicular cells. Next, we have our thyroid hormones. First, we have our thyrotropin releasing hormone or our TRH. So this is coming from the hypothalamus. Diba? As Sir Karai said, anything that has the releasing hormone usually comes from the hypothalamus. So this also stimulates the release of prolactin and not just our TSH. So leptin regulates the TRH gene and affects individuals also um, their appetite for food intake. Okay, but the assays for our TRH is usually not clinically useful. Next, we have our TSH or our thyroid stimulating hormone. So this is the principal test in assessing thyroidal function. Usually makita dyan na ninyo na when we are testing for thyroid panel, dili dyan mawala si TSH. Okay, the alpha subunits has the same amino acid sequence as your LH, FSH, and HCG, but the beta subunits carries specific information, and the gold standard in measuring the TSH is through mass spectroscopy. In this table, we can see levels of our T4, T3, free T4, and free T3, and our TSH, depending on the condition. So, pag hyperthyroidism, di ba na-expect na to, since hyper siya, so dapat mo taas jud ang iyahang values. However, makita ninyo sa table na whenever it is primary hyper or primary hypo, the TSH is opposite sa kanang other na mga values. If primary hyperthyroidism, all are increased except sa TSH. Pag secondary na hyperthyroidism, everything is increased. Pag subclinical, ang ang affected lang is ang TSH, wherein normal tanan except mubaba ang ato ang TSH. Pag primary hypothyroidism, so take note, hypo meaning baba, so supposed to be baba tanan, but since primary siya, opposite jud ang TSH niya. So primary hypo, baba ang tanan except sa TSH. Primary hyper, taas ang tanan except sa TSH. So secondary, pag secondary, uniform tanan, so tanan baba. Pag subclinical naman na hypo, so increased ang TSH and normal ang T4, T3, and FT4. Okay. Non-thyroidal illness or NTI is decreased during acute phase of illness and decreased siya if within or above reference range siya and normal once the acute illness has been resolved siya. Okay. And then next you have your thyroxine or your T4 or T4. It is measured by immunoassay after hormone is separated from the carrier protein. Ang reference range sa ato ang T4 is 5 to 12 micrograms per TL in adults and it is slightly lower in children. We have what we call our T4 thyrotoxicosis. So it has ingon ani na mga symptoms. So pag T4 thyrotoxicosis, increased ang T4, however, normal or decreased ang T3. Diba usually makita nato na kung unsa ang T4, usually nganana po ang T3. Pag taas ang T4, taas po ang T3. Pag baba ang T4, baba po ang T3. However, pag it is a T4 thyrotoxicosis, taas jud ang T4 and then normal or decreased ang T3. And this can occur in patients on amiodarone or following iodine contrast media. We also have our T3 thyrotoxicosis, decreased ang TSH niya, decreased or normal ang T4, and only ang T3 ang increased. And it is more common in a toxic nodule or elderly. Okay. And then we have our severe NTI or our euthyroid 6 syndrome. So decreased ang T4 and T3 and it is an adaptive response to reduce metabolic demands and conserve protein stores and associated usually with poor prognosis. So usually lala na jud kaayo if naanatay ingon ani na syndrome. Baba na T4 and T3. We have our free thyroxine or our FT4. Okay, so this is the biologically active fraction of our T4, diba? Because most of the T4 are bound to either TBG or sa albumin and only point something percent ang free and is metabolically active. Okay, the traditional reference technique is the equilibrium dialysis. Okay, traditional reference technique siya because it is unaffected by changes in binding protein and concentration and also the dialyzing serum against a non-protein buffer using a membrane impermeable to proteins. The gold standard still is the tandem mass spectroscopy or our EDMSMS. However, it is costly and time-consuming and usually ill-suited to meet high-volume demands. So, ang mainstay gihapon na ginagamit in measuring all thyroid hormones are our immunoassays. And next, we have our T3 or our triiodothyronine. So, this is useful in confirming the diagnosis of hyperthyroidism when TSH is suppressed and there's only minimal or no increase in T4. Okay, so usually kina-expect nato na especially pag primary siya and decreased ang ato ang TSH and we are suspecting hyperthyroidism. If gamay lang ang increase sa T4, we need to confirm it with the level of the T3. So dapat kung hyperthyroidism siya, whether primary or secondary, taas jud ang both T3 and T4. Okay. And it is generally measured using immunoassay. It is less bound to protein than T4. It is more free and diffusible state and the reference range is usually 60 to 160 microgram per DL or 0.9 to 2.46 nanomole per liter. Okay. Usually, it is not useful in evaluating patients suspected of having hypothyroidism, but usually decreased siya in severe hypothyroidism. Okay, and anti-4 niya is usually um, less than 2 microgram per DL or 32 nanomole per liter. We also have what we call our free T3 or FT3. It is less widely available and less widely standardized. So, ang usual nato na pangita or gina-measure is our total T3. Okay. So 90% of our hyperthyroidism, there is an increase of T4 and T3. And usually, mas mo increase ang T3 than T4. Okay, pareha sila increased, pero mas dako ang value sa ato ang T3 than the T4. And then we also have what we call our reverse T3 or RT3. It is a metabolite of T4. It is an inactive form. Okay, so during NTI, there's an increase in RT3 and the T3 is diminished. And it is increased also in healthy newborns and the measurements are of little clinical utility. So wala kayo ni siya measured jud sa lab. Next, we have our thyroglobulin or RTG. Okay. It is synthesized and secreted by thyroid follicular cells and helpful in monitoring for recurrence or persistence of well-differentiated thyroid carcinoma. It is of no use in patients with undifferentiated thyroid malignancies and also in serum na siya ay 45 nanomole per liter. The serum thyroglobulin concentration reflects thyroid mass. So usually, ang thyroglobulin nato is useful when screening for thyroid carcinoma. Okay, next we have our recombinant human TSH or our rhTSH. It is commonly used in patients with thyroid cancer for the presence of residual or recurrent na disease. Okay, and then we also have our thyroxine binding globulin or our TBG. Diba? As we said kaganina na 70% of our T4 7, ano ba, is tawag ani attached to TBG. Okay. Um, so it is the main serum carrier protein para sa ato ang both T4 and T3 and the measurements may be helpful in patients who have serum T4 and T3. So the levels do not agree with other lab parameters or thyroid function or that are not compatible with clinical findings and measured by immunoassay with a reference range of 150 to 360 nanomole per liter. Okay. Next, we have our thyroid autoantibodies. We have first our TPO antibody or our thyroperoxidase antibody. So this is involved in the tissue destruction process associated with Hashimoto thyroiditis and atrophic thyroiditis. It may be cytotoxic to the thyroid gland and may be a risk factor for future thyroid dysfunction. So, like we said, it is autoantibodies. So, it is an antibody to the self antigens. So, when we have our autoimmune disease, such as our Hashimoto thyroiditis, this autoantibody can be cytotoxic to thyroid gland. Okay, next we have our thyroglobulin, as we mentioned earlier. So it is present in 10 to 15% of normal people, present in 60 to 80% of patients with Hashimoto thyroiditis, and also 50 to 60% of those with Graves' disease. And next we also have our TR antibodies or our TSH reception and antibodies, also known as our thyroid stimulating immunoglobulin or TSI, and it is used to predict the outcome of Graves' patients treated with drug therapy. An increase in the antibody titer would also mean a decrease in the titer would mean an increased chance of remission following a 6 to 12 month therapy. So, anti-R antibodies are very helpful sa ato ang Graves' disease. Anti-PO antibodies is helpful sa ato ang Hashimoto thyroiditis. So, our Graves' disease, okay, people, makita nato na na sila autoimmune condition in which goiter and hyperthyroidism are induced by steroid-stimulating antibodies that mimic the action of TSH on the thyrotropin receptor. Okay? So, pag Graves' disease, naatay immunologic mimicry that is happening. Okay? Instead of actual TSH, uh, releasing or stimulating the release of our T3 and T4. We have thyroid stimulating antibodies that only mimic the action of TSH. So nagasobra-sobra ang release and there is no sort of negative feedback loop na nagkakahitabo. So masobra ang release sa ato ang thyroid hormones causing goiter and possible thyrotoxicosis as well. Um, and then because of the antibodies that mimic the action of our TSH, and then it causes an increase in the stimulation of the release of our T3 and T4. Okay. Next, uh, we also have the urinary iodine measurement. So iodine is required for normal thyroid hormone production. Okay, most that are ingested are excreted in the urine, and urinary iodine excretion provides an accurate estimate both of our dietary iodine intake. We have also what we call our neonatal hypothyroidism or our congenital hypothyroidism. So the screening is blood from the heels, not hell, but heel stick onto filter paper 2 to 4 days of age prior to discharge. So we usually test it sa our newborn screening, okay, our congenital hypothyroidism. Ang ginatest nato should be the T4 and the TSH. Um, that must be both because if only T4 lang ang itest, it could have a high false positivity rate, and if only TSH, it could run the risk of missing central hypothyroidism. If increased naman ang TSH nato when testing for the T4 and TSH, so this is the most sensitive test for the diagnosis of congenital hypothyroidism. And if makita nato na siya, pag maabot na ang results sa ato ang newborn screening, it must be retested at 2 weeks of age or 2 weeks after the first screening was carried out. And usually ginabuhat ni siya for premature infants, NICU infants, infants of multiple gestation, and those that have very low birth weight. So, kasagaran sa ato ang mga infants, these infants who are premature, gikan sa NICU, and infants of multiple gestation, and those with very low birth weight, dili lang sa neonatal hypothyroidism, but murag as a general rule, if ingon ani ang condition nila when we did the initial newborn screening, they will be retested jud at 2 weeks of age. So after 14 days, mobalik sila sa hospital or kung asa man sila first nagpa-test, and they will be another set of newborn screening will be performed again sa baby. Okay, and this is just to assure na or ensure na we didn't miss any um, diseases that could be screened na medyo baba pa ang levels due to their immaturity or low birth weight or anything that could affect the levels of anything that was being of the factors na kanang being tested sa blood. Okay, that is why if ingon ani ang ilahang mga circumstances, we have premature infant, NICU infant, infant of multiple gestation, and very low birth weight. Usually ginapabalik sila sa hospital after 2 weeks or pagka 14 days old na sila or 2 weeks after the first screening para i-retest sila. Okay, for newborns, if their TSH is less than 10 MIU per liter, so no further testing is necessary. Okay, if 10 to 20 ang value niya, so we have another repeat in 2 to 6 weeks. And if more than 20, then it would require an endocrinology evaluation. Okay, next you have your Hashimoto's thyroiditis. It is an autoimmune disease of the thyroid gland caused by binding of sensitized T lymphocytes and their autoantibodies to cell membrane causing cell lysis and an inflammatory reaction resulting in cellular damage. So we have, like we mentioned, we have positive TPO antibodies or thyroperoxidase antibodies, and we also have increased in TSH. So, syempre makita mo na nag-increase ang TSH, so nag-increase po ang secretion of the T3 and the T4. Okay. So, nag it is autoantibody gihapon siya since autoimmune disease siya, so it is still causing damage to our own na cells. Okay, nag-inflammatory reaction siya. And then usually anything that causes an inflammatory reaction, most especially if it is an autoimmune disease or kapag nag-react siya or nag-stimulate siya o reaction from the complement na system or complement pathway, na adjud na siya resulting na cellular damage. Sometimes the coping mechanism of the body, um, especially if there is an inflammatory response, causes also damage sa ato ang cells. That's why as much as possible, we don't want to reach pa ang ingon ana na stage na grabe na ang pag-fight sa body, na pati ang own cells niya ano na siya, murag ma-appeal na siya sa mga ginapatay sa atoang cells. Okay. So we have what we call our L-thyroxine, or sa uban is levothyroxine. So it is taken before meals, same time every time. So if nagatake ka every 8 a.m., so dapat every 8 a.m. 4 hours from any other medication and vitamins. So the therapeutic goal niya when it is being taken for primary hypothyroidism is to reach a serum TSH of zero point 0.5 to 2.0 MIU per ml. And therapeutic goal niya in central hypothyroidism is to reach a serum FT4 in the upper third of the reference interval. So this is also used to suppress TSH in patients with well-differentiated thyroid carcinoma. Yeah. So TSH is used to monitor treatment in those receiving hormone replacement therapy and monitor adequacy at suppression in patients with thyroid malignancy. Okay. So uh, we have what we call also our calcitonin. Diba? Ito secreted by the parafollicular cells, also known as our C cells, as we mentioned sa kaganina. It also secretes CEA, chromogranin, and ACTH, okay, the parafollicular cells. Calcitonin serves as a tumor marker for MTC, or medullary thyroid carcinoma, together with CEA, and a diagnostic test niya for the medullary thyroid carcinoma would be thyroid sonograms and FNAB, or our fine needle aspiration biopsy. Okay. It is usually mas taas in males more than females due to um, the larger C cell mass in men. Okay, so since mas dako ang mass sa C cells in men, so mas dako po ang value of C cells or calcitonin in men rather than women. Okay, so this is usually markedly elevated in children 3 years old, especially those younger than 6 months old. Okay, and then 3 to 6 months post thyroidectomy levels, um, gina-measure siya after uh, thyroidectomy. Okay, and if detectable calcitonin levels are found, it indicates the presence of remnant thyroid tissue or regional distant metastasis or metastasis. So, supposed to be um, 3 to 6 months after thyroidectomy, dapat dili na ito makakita og detectable calcitonin levels. Otherwise, it could indicate, if makakita pa ta, it could indicate the presence of remnant na tissue, meaning wala jud nakuha ti buok na katong thyroid tissue. And it could also mean na wala lang nag-stay sa thyroid but then metastasized na siya elsewhere. So, distant metastasis. Okay, so that is it for your hormones from the hypothalamus and pituitary gland and also your thyroid hormones. Thank you so much, and I hope you study for this for our upcoming quiz.